I'm Philip Ward, Editor-in-Chief of Aren'tManyEurope.com. One of the standout sessions at ECR on day one of the Congress is about the future of radiology, about are radiologists imagers or doctors? And Professor Jim Reekers from Amsterdam is speaking about subspecialization and where this fits into the whole picture. So, Jim, is subspecialization the answer? What are your feelings on this?
Actually, if you come to the lecture, you will see the last slide is going to say it's the only answer. And the reason for that is that I think that reading pictures nowadays is something, well, it's been done by radiologists, but there's no reason that other specialists shouldn't do that. I mean, if we can learn to report on things, they can also do that. And my biggest worry is that we are not going to be needed anymore when we are really not going to be partner with our clinicians. That's actually my biggest worry. So my emphasis on subspecialization is more than being a good doctor or being a super specialist, but it's more that being part of a team. And if you're part of a team, and it doesn't matter what kind of team, it could be the team who's dealing with oncology or the team who's dealing with interventional, then you're going to be needed in that team, and your advice is going to be very, very good and very helpful. But if you're not going to be in that team, despite how good you are and how good your reports are, but if you're not in that team, you're not going to be one of the guys and you're not going to survive. That's my biggest worry. If I can give an example, medicine has changed over the last 20 years dramatically, and you see all sort of doctors super specializing in things, and nobody can understand or can tell me why it's not possible for them to learn about all sort of new technologies and not take also reading the pictures or the CT scans on the side. I mean, if you're a super specialized pediatric doctor, why shouldn't you read your own images? I mean, there is no reason not to do that. We're not protected. So, but if you're around, if you're part of their team, that you are the team with the others together, then this is not going to happen. So it goes a little bit further than being good, being accurate, being super good. It's more being part of the team. That is my message. If you're not part of the team, you won't be there.
And maybe it's a question of attitude as well. It's yes, bringing something to the table that is different, something that is fresh, something that is important to patient care, but also a question of attitude on how you relate to others and how you incorporate yourself into that team.
I'll give you a good example how we've done things in my hospital. For instance, we have an MDT every week on vascular problems. It's the vascular surgeon who's going to present the pictures, or the junior vascular surgeon is doing that. I'm sitting in the audience next to the other doctors, and I'm into the discussion, and I discuss things, and I propose things, and so I'm not the guy who's showing the picture, I'm the guy who's part of the team. And that is what I mean with subspecialization. Be involved, and not only be good or be accurate, but be involved. And the involvement comes from, well, subspecialization.
Excellent. Now, your own field, interventional radiology, would you regard that now as a separate subspecialty in its own right?
We have to be very careful here. Yes, it is a separate subspecialty, but it's not a specialty. So it's always, and it should always be part of radiology, because looking at images or performing image-guided treatment cannot be seen away from MR, CT, everything else you do. So yes, you have to live in a house, and the house is radiology, but you have a different room in the house, and you decorate that room the way you think it should be decorated, but you should not leave that house. So, I mean, going out of the house is going to be devastating. Mm-hmm. So there is a little bit of discussion going on here with interventional radiology. Subspecialization, yes. But should it be like in the US, where interventional radiology is a specialty on its own? No, that's not the way forward. Okay. So it should be within. That's the main thing.
Would you urge all radiologists now who are perhaps relatively newly qualified, should they do interventional work? Would you encourage them to do procedures?
Yes, I think there's still a big market for them. But again, as I said before, not as a service, but as a partner of the team, because otherwise, I mean, you see it in many countries that vascular surgeons do all sort of procedures, not in my hospital, because Why should they do that? I'm a partner. I'm not their radiologist. I'm their partner. So they do an aneurysm, and I do something else, or we do it together. And so I think if you want to go into interventional, you should really know a lot about vascular surgery. You should know a lot about vascular medicine, much more than an average radiologist. Even if he's very good specialized, should know. You should really be able to judge also if a patient needs a bypass, and if bypass is how the bypass is done. So that is, you should be much more a team player.
Yeah. Now, I don't think anyone would disagree with that. I think there is quite a lot of realization about the importance of a team. The reality, though, is outsourcing and teleradiology is breaking down and fragmenting that team. How would you regard outsourcing and teleradiology in that respect, in breaking up the team?
Well, you know, radiologists come from dark basements where nobody could find them, and the only thing they communicated which was little notes where they gave reports. And now we're more or less in the hospital, and in my situation we are part of a team. And now with teleradiology we're kind of going back to the basement. We're not going to have any direct contact to other physicians. We don't have any contact to patients, no nothing. So actually what we are doing is we are outsourcing not radiology, we are outsourcing radiologists. So we just now remote radiologist, and if you're not seen in the hospital, they is going to say, what was his name again? What did he look? He was bald, was he? No, he had a moustache. And so you're out. If you're not seen, you don't exist anymore. So the mere existence of you as a radiologist is your presence in the hospital.
But outsourcing, Jim, the genie is out of the bottle. The outsourcing and teleradiology is here. It can't be put back into that bottle, can it?
So it's going to kill. I'm really afraid it's going to kill radiology, because let's be very frank on this. I mean, we have a good profession, and we do 5 years of education, and we do a lot of other education, but you can't explain to me why somebody else who is not trained as a radiology with a lot of knowledge about a subspecialty cannot look at the images themselves. They can, but you have to take away the reason for them to do that, and that's because you're present. If you're not present, there's a very nice survey done, it was published at the RSNA a couple of years ago. Only 40% of the people really read the full report. They're much more interested in the pictures. So if we are now replaced by pictures and 40% reports, we're not existing anymore. So the whole thing is being there and being of extra value by being there. So outsourcing yourself. I mean, I think teleradiology can do perfect reports, but nobody cares, because they look at the pictures themselves if they want. They don't care about the reports. They want you. They want you to be around. They want your input. They want your knowledge at the moment when it's needed, and not on some remote place. So I think teleradiology is going to be the biggest trouble for radiology. And if it goes on like this, I won't see it, because I'm going to retire by that time. But I think radiology will go out of the hospital.
That's quite a bleak picture, though.
I think it's very, very sad if we don't pay attention, and if we continue to provide this sort of remote service, which is no service at all. It's just, it brings us back to the time when the radiologist was seen as a photographer. And actually, when you do teleradiology, you're again the photographer with a little presentation on. But that's not enough. You should be there, physically be there, wearing a white doctor's outfit, be seen as a doctor, and then you have a real life.
So would you like to see societies and organizations like the ESR being stronger, being less tolerant maybe of teleradiology?
No, it's not that you cannot say that you shouldn't do it. You should only point out where the difficulties are and where the threats are. On the other hand, you have to remember many subspecialties, like what I said, pediatric people, or also the pneumatologist, urologist. Everybody has now incorporated imaging into the curriculum. So what we should do, we should really be very strong in that, and we should be better, and we should really set standards for that. That's much more important. You cannot say you cannot do teleradiology, but you should make it just unnecessary for people to do that. And of course, I understand the situation in the UK where they have shortage of radiologists. But in my country, I think we have 70 or 80 unemployed radiologists. So there's absolutely no need for teleradiology.
Excellent. Yeah. Well, a very strong, clear message. Jim, thank you very much for your time. And I hope the rest of the Congress goes well for you.
Thank you.
Thank you.